Epistaxis. What is epistaxis? Bleeding from inside the nose is also known as epistaxis. Why does it occur? There are many different reasons. Most important ones are among children due to trauma due to nasal picking. Another important cause in children is foreign body and nose, infections of nose, deviated nasal septum, raised blood pressure, kidney disease, and liver disease. What are the sites of epistaxis? 1. Most important site of epistaxis in nose is Little's area. In 90% of cases, epistaxis occurs from here. It is situated in antero-inferior part of nasal septum. 4 arteries: anterior ethmoidal, septal branch of superior labial, septal branch of sphenopalatine, and the greater palatine artery, anastomose here. 2. Posterior part of nasal cavity. After bleeding from here, blood flows directly into pharynx. Diffuse. It is bleeding from septum and lateral wall. This is often seen in general systemic disorders and blood dyscarsias. How will you manage a case of epistaxis? In any case of epistaxis, it is important to ask the patients: 1. Mode of onset. Was it spontaneous or was there fingernail trauma? 2. Duration and frequency of bleeding. 3. Amount of blood loss. 4. Side of nose from where bleeding is occurring, or is it occurring from both sides of nose? 5. Any known bleeding tendency in patient or family. 6. Any history of drug intake, analgesics, anticoagulants, etc. How will you treat epistaxis? 1. First aid. Most of time, bleeding occurs from Little's area and can be controlled by pinching nose with thumb and index for 5 minutes. This compresses blood vessels of Little's area. 2. Cauterization. Useful in patients where bleeding point has been located. 3. Anterior nasal packing. 4. Posterior nasal packing. General measures. 1. Make the patient sit up. 2. Reassure the patient. 3. Keep check on pulse and BP. Nasal polyp. What is a nasal polyp? Nasal polyp are fleshy swellings that develop in the lining mucosa of the nose and paranasal sinuses, air-filled spaces linked to the nasal cavity. They are non-cancerous growths. What causes nasal polyp? The mucosa is a very wet layer that helps protect the inside of your nose and sinuses and humidifies the air you breathe. During an infection or allergy-induced irritation, the nasal mucosa becomes swollen and red. With prolonged irritation, the mucosa may form a polyp. A polyp is a round growth, like a small cyst, that can block nasal passages. Although some people can develop polyps with no previous nasal problems, there's often a trigger for developing polyps. These triggers include A. Chronic or recurring sinus infections. B. Asthma. C. Allergic rhinitis. What are the symptoms of nasal polyp? Polyps can grow large enough to block your nasal passages, resulting in chronic congestion. Symptoms can include 1. Nasal congestion, a sensation that your nose is blocked. 2. Runny nose. 3. Postnasal drip, which is when excess mucus runs down the back of your throat. 4. Reduced sense of smell. 5. Breathing through your mouth. 6. A feeling of pressure in your forehead or face. What are the major types of nasal polyp? There are 2 major types of nasal polyp. 1. Antrochoanal, single, unilateral. Originate from maxillary sinus, usually found in children. Infections is the common cause. 2. Ethmoidal, bilateral, originate from ethmoid sinuses, usually found in adults. Allergy is the common cause. How are nasal polyps diagnosed? A doctor will generally be able to make a diagnosis after asking about symptoms and examining the patient's nose. The doctor may also order the following test. Nasal endoscopy. A narrow tube with a small camera is inserted into the patient's nose. CT scan. This enables the doctor to locate nasal polyps and other abnormalities linked to chronic inflammation. The doctor will also be able to identify any other obstructions. What is the treatment for nasal polyps? The following treatments are commonly used for nasal polyps. 1. Steroids. The doctor may prescribe a steroid spray or nose drops, which will shrink the polyps by reducing inflammation. 2. Steroid tablets. In cases of larger polyps or more severe inflammation, the patient may be prescribed steroid tablets. 3. Other medications. Other medications may be given to treat conditions that are making the inflammation worse. Examples include antihistamines for allergies, antibiotics for bacterial infections, and antifungal drugs for fungal allergies. 4. Surgery. Polypectomy. This is the most common procedure for the removal of polyps. The patient is given general anesthesia. A long, thin tube with a video camera is inserted into the patient's nose and sinuses. Polyps are then cut out using microtelescope to visualize it and surgical instruments to cut it. After surgery, the patient will most likely be prescribed a corticosteroid nasal spray to help prevent reoccurrence. What is vertigo? Vertigo is a sense of rotation, rocking, or the world spinning, experienced even when someone is perfectly still. What is the physiology of balance? The human balance system works with our visual and skeletal systems to maintain orientation or balance. Visual signals are sent to the human brain about the body's position in relation to its surroundings. These signals are processed by the brain and compared to information from the vestibular, visual, and skeletal systems. Our brain receives inputs from our eyes, muscles, joints, and vestibular system in our ears. Then it processes these nerve impulses so that it can give the person a correct perception of the environment. Our ears contain special parts like the saccule, utricle, and 3 semicircular canals, which are all part of the vestibular apparatus. The purpose of vestibular apparatus is to provide the brain the correct perception of equilibrium, balance, spatial orientation, and motion. The parts that are responsible for vertical orientation are the saccule and utricle. The rotational movement is detected by the semicircular canals that contain fluid, known as endolymph. The endolymph moves and triggers the sensory receptors within the canal, which sends nerve impulses to the brain regarding the movement. Impulses from both canals of the side of the head would normally send symmetrical impulses in order for the brain to interpret the impulses properly. Types of vertigo. There are 2 possible causes of vertigo: peripheral vertigo and central vertigo. Peripheral vertigo. Peripheral vertigo refers to the disorders that involve disturbances in the inner ear. The common disorders that may affect the inner ear, thereby causing the person to experience dizziness or vertigo, include vestibular neuritis, inflammation of the vestibular nerve, which is responsible for taking the nerve impulses from the semicircular canals in the inner to the brain; labyrinthitis, inflammation of the labyrinth, which is also in the inner ear and most of the time may also involve the vestibular nerve. Both of these disorders are usually caused by a viral infection that may have reached the inner ear. Other causes include Meniere's disease. This occurs due to increased fluid in inner ear. Benign paroxysmal positional vertigo, or BPPV. This results from the movement of the otolith, which is a very small particle made of calcium inside the ear. The otolith organs detect the movement of your head and its relation to gravity. For some reason, the otolith can be dislodged and moved into the semicircular canals and affect the movement of the fluid inside, thereby causing it to send irregular nerve impulses to the brain, making the person get dizzy. How to treat BPPV? The most common and effective treatment for BPPV is known as the canalith repositioning procedure. The procedure consists of several simple and slow maneuvers for positioning your head. The aim is to move the particles from the semicircular canal to the utricle, where they don't pose a problem. Each position is held for around 30 seconds, after which any symptoms or abnormal eye movements stop. This procedure is more widely known as Epley's maneuver. Central vertigo. Central vertigo refers to the dizziness of vertigo that result from a problem in the brain. The area of the brain that is usually affected is the brainstem or cerebellum. How to diagnose vertigo? Vertigo can be diagnosed based on 1. Clinical history and symptoms being told by patient. 2. Blood test to check for presence of infection. 3. Romberg test. The doctor will have you stand with your eyes open and feet together, then maintain your balance while your eyes are closed. 4. Vestibular testing to check for any involuntary movements of the eyes. Nystagmus. 5. Fukuda-Unterberger test. In this test, the patient will have to close the eyes and march in place while trying not to lean to the side. In some instances, the doctor will require you to undergo diagnostic imaging tests like CT scan or MRI to rule out central causes of vertigo or any tumor presence. What is the medical treatment? Treatment of vertigo depends on the causative factor. Peripheral vertigo can be treated by bed rest, avoiding sudden position changes, and use of vestibular blocking agents or VBAs. These medications help relieve the inflammation in the inner ear, relaxes the muscles, and prevent other symptoms associated with vertigo like nausea and vomiting. What is the surgical treatment? Surgery can also be another treatment option, especially for persons with Meniere's disease who are suffering from intense and frequent vertigo attacks. Endolymphatic sac procedures. This involves the decompression of the endolymphatic sacs by removing a tiny part of the bone to allow better fluid absorption or decrease fluid production. A shunt may also be put in place to facilitate fluid drainage from the inner ear. Labyrinthectomy. The removal of both the hearing and balance organs of the ear. This is only done when the patient's affected ear already has total hearing loss. Vestibular nerve section. This procedure is done by cutting the vestibular nerve, which is the movement and balance sensors in the inner ear. This can help relieve vertigo attacks and at the same time prevent hearing loss. Prognosis. Most of the symptoms associated with peripheral types of vertigo usually resolve on its own within a short period of time. Otherwise, you need to see a doctor to make a treatment plan. Otosclerosis. Otosclerosis, also called otospongiosis, is disease of bony labyrinth and ossicles in ear who become knit together into an immovable mass. It mostly involves otic ganglion and stapes in which normal bone is replaced by spongy bone. Causes. It is mostly inherited as autosomal dominant pattern, so patients have positive family history. It is more common in white races. It affects females twice as males and mostly discovered during or just after pregnancy. Mostly starts between 20 to 30 years of age. Chronic measles infection predisposes patient to otosclerosis. Otosclerosis is often associated with osteogenesis imperfecta, called Van der Waals syndrome. Syndrome consists of otosclerosis, osteogenesis imperfecta, and blue sclera of eyes. Symptoms. Patient presents with bilateral conductive hearing loss or mixed type, both conductive and sensorineural hearing loss. Tinnitus, vertigo, monotonous speech, and paracusis willesi. Patient hearing better in noisy environment. On examination, tuning fork test. Negative Rhine and Weber lateralized to diseased ear. Conductive types. Eustachian tube function is normal. On audiometric testing, 1. Otoscopy. Reddish hue on tympanic membrane called Schwartz sign. 2. Pure tone audiometry. PTA. Shows dips at 2000 Hz, called Carhart's notch. 3. Tympanometry. Curve of ossicular stiffness present, as pattern on graph. Treatment. 1. Non-surgical. A. Sodium fluoride as dietary supplement. B. Hearing aids for sound amplification. 2. Surgical stapedectomy with prosthesis, in which diseased stapes is replaced. Contraindication for surgery. A. Only hearing ear. B. Associated Meniere's disease. C. Young children. D. Athletes. E. Frequent air travelers. F. Divers.
External ear anatomy. Today, we are going to learn about anatomy of external ear. The ear is divided into 3 parts. 1. External ear. 2. Middle ear. 3. Internal ear. The external ear is again divided into 3 parts, which will make it easier to remember. Its 3 parts are 1. Auricle or pinna. 2. External acoustic canal. And 3. The tympanic membrane. 1. Auricle or pinna. The entire pinna, except its lobule, which is made of fat, and the outer part of external acoustic ear canal, are made up of a framework of a single piece of yellow elastic cartilage, which is then covered with skin. There is no cartilage between the tragus and crus of the helix, and this area, which is without cartilage, is called the incisura terminalis. An incision made in this area will not cut through the cartilage, since cartilage are unable to heal properly, and therefore this area is used for endural approach in surgery of the ear. Pinna is also the source of graft materials for the surgeon, cartilage from the tragus, perichondrium from the tragus or concha, and fat from the lobule are frequently used for reconstructive surgery of the middle ear. The conchal cartilage has also been used to correct the depressed nasal bridge, while the composite grafts of the skin and cartilage from the pinna are sometimes used for repair of defects of nasal ala in nasal surgery. 2. External acoustic auditory canal. It extends from the bottom of the concha to the tympanic membrane and measures about 24 mm along its posterior wall. It is not a straight tube. Its outer part is directed upwards, backwards, and medially, while its inner part is directed downwards, forwards, and medially. Therefore, to see the tympanic membrane, the pinna has to be pulled upwards, backwards, and laterally so as to bring the two parts in alignment. The canal is divided into two parts, A. Cartilaginous, and B. Bony. A. Cartilaginous part. It forms outer 1/3 8 mm of the canal. Cartilage is a continuation of the cartilage which forms the framework of the pinna. B. Bony part. It forms inner 2/3 16 mm. 3. Tympanic membrane or the drumhead. It forms the partition between the external acoustic canal and the middle ear. It is obliquely set and as a result, its postero-superior part is more lateral than its antero-inferior part. It is 9 to 10 mm tall, 8 to 9 mm wide, and 0.1 mm thick. Tympanic membrane can be divided into two parts, pars tensa, pars flaccida.
Earache is also known as otalgia in the medical term. There are two types of earache or otalgia. First is primary otalgia. The cause of this earache lies within the ear, and we will list the causes shortly. Second is secondary otalgia. In this case, the causes of earache are somewhere else other than the ear. But because of shared nerve supply with the affected area, the patients will feel that they are also experiencing earache. Now, we will enlist the major causes of primary earache. First, we divide the ear into 5 major parts: pinna, external auditory canal, middle ear, mastoid, and inner ear. In pinna, the causes of earache can include laceration or bite, hematoma, otitis externa, perichondritis, preauricular sinus, frostbite, or sunburn. In external auditory canal, the causes can include impacted wax, foreign body, furuncle, otitis externa, keratosis obturans. In the middle ear, the causes can include acute otitis media, secretory otitis media, traumatic perforation, hematympanum, barotrauma. In mastoid, the causes can include mastoiditis, abscess, granular mass. In inner ear, the causes can include acoustic trauma, Meniere's disease. For secondary earache or referred pain, the major nerves are fifth or trigeminal nerve. It carries pain to the ear from teeth, oral cavity, or temporomandibular joint. Seventh or facial nerve. It carries pain to the ear from vestibular schwannoma and herpes zoster infection. Ninth or glossopharyngeal nerve. It carries pain from the oropharynx area as well as the tonsil area. 10th or vagus nerve. It carries pain to the ear from hypopharynx and larynx area. Second or third cranial nerves. These carry pain to the ear from cervical spine degeneration disease, as well as whiplash, trauma to the spine. If you like this video, then make sure to subscribe and share our channel, Free Medical Education, as we will be covering more medical knowledge in upcoming videos.
Acute epiglottitis. Causes, symptoms, treatment. It is an acute inflammatory condition confined to supraglottic structures, which include epiglottis, epiglottic folds, and arytenoids. There is marked edema of these structures which may obstruct the airway. What causes epiglottitis? It is a serious condition and affects children of 2 to 7 years of age, but can also affect adults. H. influenza B is the most common organism responsible for this condition in children. Clinical features. 1. Onset of symptoms is abrupt with rapid progression. 2. Sore throat and dysphagia are the common presenting symptoms in adults. 3. Dyspnea and stridor are the common presenting symptoms in children. They are rapidly progressive and may prove fatal unless relieved. 4. Fever may go up to 40 degrees Celsius. It is due to septicemia. Patient's condition may rapidly deteriorate. Examination. 1. Depressing the tongue with a tongue depressor may show red and swollen epiglottis. Indirect laryngoscopy may show edema and congestion of supraglottic structure. This examination is avoided for fear of precipitating complete obstruction. It is better done in operation theater, where facilities for intubation are available. 2. Lateral soft tissue X-ray of neck may show swollen epiglottis, thumb sign. Treatment. 1. Hospitalization. Essential because of the danger of respiratory obstruction. 2. Antibiotics. Ampicillin or third-generation cephalosporin are effective against H. influenza and are given by parenteral route, IM or IV, without waiting for results for throat swab and blood culture. 3. Steroids. Given in appropriate doses, relieve edema and may obviate need for tracheostomy. 4. Adequate hydration. Patient may require parenteral fluids. 5. Humidification and oxygen. 6. Intubation or tracheostomy may be required for respiratory obstruction.
Difficulty swallowing intro. When a patient says they are having difficulty swallowing, they may be referring to one or a combination of the following symptoms. Dysphagia, which means food is unable to pass through smoothly or gets stuck. Odonophagia, which means that swallowing is painful. Reflux and regurgitation, which means food or gastric secretions come back into the throat or mouth. Aspiration, in which the food or drink goes down the trachea instead of the esophagus. This can further lead to aspiration pneumonia. Gagging, in which patient may feel that the food is causing them to throw up and vomit. Globus pharyngeus, a feeling of a lump in the throat. Xerostomia, it means dry mouth, which may itself lead to dysphagia or odonophagia. Our main goal in this presentation is to discuss an approach to a patient with dysphagia, its relevant history and workup, and what are the main differentials and some general management options for dysphagia. Many specialists have to deal with patients of dysphagia, such as otorhinolaryngologists, gastroenterologists, speech therapists, dentists, internists, and geriatricians, to name a few. Dysphagia is a fairly common cause of morbidity in the elderly population. The swallowing mechanism. Let's begin by reviewing the physiology of the swallowing mechanism. It is generally divided into 3 phases. Oral phase, in which the food is chewed and lubricated to form a bolus. Pharyngeal phase, in which the movements of the soft palate, larynx and epiglottis separate the air passage from the food passage so that food and drink are not aspirated into the nose or trachea. Esophageal phase, in which the food passes down the esophagus via peristalsis into the stomach. A disruption in any one of these phases could result in dysphagia, and difficulty in the pharyngeal phase especially could lead to aspiration. Classification of dysphagia. Dysphagia is classified according to site, whether it is oropharyngeal or esophageal, and the type of disorder, whether it is a structural disorder or a motility or propulsive disorder. The differential diagnosis for dysphagia could also be divided according to the cause: congenital, infections, trauma, inflammatory, autoimmune, neoplastic, neurological, motility disorders, iatrogenic, and mechanical causes. History and workup. So as you have seen, a multitude of conditions can cause dysphagia. When a patient presents with difficulty swallowing, here are a few important points to consider in taking the patient's history. Is it true dysphagia, or other related problem like odonophagia, etc.? What is the onset and duration? Any coughing or airway issues, to check for aspiration? Is it continuous, worsening, or intermittent? What is the location? Is it oropharyngeal or esophageal dysphagia? Is it more for solid food or liquids? Is there associated regurgitation or reflux? Does the patient have pain, weight loss, and/or dehydration? This is to assess the general condition of the patient. Examination. Oral and throat examination should be done, but the main way to assess dysphagia is to ask the patient to swallow solid food and liquids in front of you. Investigations. We shall start with baseline investigations. Chest X-ray can give us a quick and rough idea about the esophagus, but more importantly, it gives an idea about any aspiration pneumonia. X-ray neck, antero-posterior and lateral view, can give a quick and rough idea about the pharynx, larynx and upper esophagus. If a neck pathology is suspected to cause dysphagia, CT scan or MRI may also be advised. Complete blood count, urea and electrolytes can give an idea about the patient's condition, e.g., does he/she have any electrolyte disturbance due to dehydration? The investigations specific for dysphagia are fiber optic direct laryngoscopy, which can view the laryngeal inlet and is useful for investigating patients of oropharyngeal dysphagia. Barium swallow, in which patient is given a radio-opaque contrast to drink, and the contrast is then X-rayed as it passes through the pharynx and esophagus. Video fluoroscopy is similar to barium swallow, but instead of still images, a video clip is made of the contrast passage into the stomach. It is considered a better study than barium swallow. Esophageal endoscopy. This is particularly useful in patients with esophageal dysphagia, in which a structural lesion is suspected. Esophageal manometry. In this test, a catheter is passed into the esophagus, which measures the pressure along the length of the esophagus. This is useful in patients in which a motility/propulsive cause of dysphagia is suspected. Management of dysphagia. Obviously, the specific management of dysphagia depends on the underlying disease. In general, here are the key points while managing a patient of dysphagia. Ensure adequate hydration and replenish any deficit electrolytes, such as sodium and potassium. Patients are usually malnourished and feeding can be started via nasogastric tube. If NG tube cannot be passed, then total parenteral nutrition via IV route might be needed. Patient might require feeding jejunostomy or gastrostomy for long-term feeding. Food consistency variation and diet modification might help some patient with dysphagia due to motility disorder, especially geriatric and stroke patients. Swallow positioning and pharyngo-esophageal exercises are also useful. Reduce aspiration risk by regular swallowing assessment, patient's positioning and airway protection measures. Oral hygiene with use of mouthwashes. Proton pump inhibitors, like omeprazole, might reduce the severity of discomfort of dysphagia. Antibiotics will reduce infection, especially in patients with increased risk of aspiration.
Tracheostomy is a procedure in which an artificial opening is created in the throat to assist with patient's breathing or to create an alternate airway. It is a fairly common procedure in patients with prolonged ICU stay or ventilator support. Indications for tracheostomy. Tracheostomy may be needed when there is 1. Some sort of upper airway obstruction, e.g. cancer of the larynx, laryngeal edema, etc. 2. If patient is unable to remove respiratory secretions, e.g. coma, respiratory muscles paralysis. In such cases, tracheostomy allows suctioning of the secretions and the cuff of the tracheostomy reduces further aspiration of secretions. 3. If the patient has respiratory insufficiency, e.g. chronic lung diseases, then tracheostomy might help oxygen ventilation by reducing respiratory dead space. 4. Prophylactic measures. In a patient on prolonged mechanical ventilation via endotracheal tube, there is a risk for tracheal stenosis. So in such patients, tracheostomy is done. 5. As part of another procedure. Sometimes tracheostomy is done to gain access to airway for general anesthesia, or as a precautionary measure in some patients who undergo an extensive neck surgery. Type of tracheostomy. There are various types of tracheostomy procedures, depending on the circumstances of the patient and the treatment intent. Similarly, there are various types of tracheostomy tubes, each with specific functions. The common types of tracheostomy procedures are 1. Emergency tracheostomy, 2. Elective tracheostomy, 3. Permanent tracheostomy, 4. Percutaneous tracheostomy, 5. Mini tracheostomy, also known as cricothyroidotomy. Tracheostomy can also be classified as high, mid, or low, depending on the level at which it is inserted into the trachea. Different varieties of tracheostomy tubes include cuffed, non-cuffed, double lumen tubes, tubes with speaking valves, metallic tubes, and so on. Procedure. The procedure is preferably done under general anesthesia, but emergency cases may necessitate local anesthesia only. There are variations on the technique of the procedure, but generally, these are the steps. The patient is put in a supine position, with neck extended. Skin incision, which may be transverse or longitudinal, is given on the neck. Subcutaneous fat and platysma are cut. Strap muscles of the neck are retracted or dissected away. If thyroid gland is encountered, then it is displaced upwards, or may be cut. Any blood vessels encountered along the way are ligated. Incision is given on the trachea. A hole is made and the tracheostomy tube is inserted, preferably through the second or third tracheal ring. The skin incision is closed and the tracheostomy tube is secured to the skin via stitches or simply tied around the neck. Care. After tracheostomy is done, certain precautions and care is required to ensure proper functioning of the tracheostomy tube and to prevent complications. The tracheostomy forces the air to bypass the nasal and oral passages. Hence, the air entering the tracheostomy is not adequately humidified. This dry air leads to increased tracheal irritation and secretion production. Because these secretions may lead to crusting and blockage of the tracheostomy tube, the first point regarding care is adequate suctioning of the secretions through the tracheostomy tube. Secondly, humidification of air. This can be done with humidified air attached to the tube, placing a humidifier or steam near the patient's bed, or applying a wet porous gauze onto the tracheostomy tube, although the latter is considered a crude measure. Thirdly, keep the patient under regular supervision and ensure that the tube is functioning and not dislodged. Since the tracheostomy forces the air to bypass the vocal cords, patients would not be able to speak effectively. In such cases, a notepad and bell should be provided to the patient to allow them to communicate effectively with their healthcare providers. Fourthly, if the patient has a cuffed tracheostomy in place, then the cuff should be deflated periodically to relieve pressure on the trachea. However, this may not be feasible in patients with increased risk of aspiration. In case the tracheostomy tube is damaged, infected, occluded, or non-functioning in any way, then a new tube should be inserted in place of the old one under expert supervision. Complications. Just like any invasive procedure, tracheostomy also has some potential complications. Surrounding structures may be damaged while performing the procedure. Therefore, there could be bleeding around the tracheostomy site. Tracheostomy tube may get blocked by secretions or clots, or it may get dislodged. The dry air directly entering the trachea might cause tracheitis or crusting. The patient may have initial difficulty getting used to breathing via tracheostomy, along with apnea. There may be infections of the surgical wound, trachea, or lungs. Decannulation. If the patient improves and the healthcare team determines that tracheostomy is no longer necessary, then a trial of decannulation should be attempted. Decannulation is basically the removal of the tracheostomy tube and shifting the patient back to normal breathing. The tube is occluded for 24 hours, and if the patient is able to tolerate it and breathe normally, then the tube is removed and the wound closed. If patient is unable to tolerate the tube occlusion, then progressively smaller tracheostomy tube are inserted and occluded until patient is able to resume normal breathing.
Introduction. A variety of diseases could present as a lump or mass in the neck. These could be inflammatory, congenital or neoplastic lesions. Whenever a patient presents with a neck mass, it requires some workup, especially if a malignant neoplasm, i.e. cancer, is suspected. Basic anatomy. Workup for neck masses requires a basic understanding of the structures of the neck and at which level they lie. One way to localize the different structures is to divide the neck into a number of triangles. Another way to define location is the levels system. This system is especially useful when defining enlarged lymph nodes in the neck. Lymph node groups and their respective regions in the neck are assigned numbers from level 1 to level 7. It is important to note that lymphatic drainage from the entire head and neck goes into the neck nodes. Sometimes, diseases in the abdomen could also travel to the neck nodes. This means that if there is an infection or cancer, especially in the head region, it can easily lead to lymph node enlargement in the neck. Finally, the simplest way to define neck masses is to divide them into midline or lateral neck masses. Examination. Once the patient presents with a neck mass, the main concern for the physician is whether the mass is neoplastic, i.e. cancerous, or not. Here are some important points to note in the patient's history. What is the age of the patient? Neck mass in patients less than 35 years is unlikely to be a malignant cancer. How long has the mass been present? If it is present for more than 3 weeks, then there is a suspicion for neoplasia or tuberculosis. But if it is less than 2 weeks, then it is most likely infective lymphadenitis. Is the neck mass painful or tender? Pain and tenderness are generally features of infections or physical trauma. In contrast, neoplastic lesions may be painless. What are the associated features? Is there toothache, sore throat or odonophagia? Is there associated hoarseness, dysphagia? Weight loss, night sweats or fever? Is there any history of tobacco use? Any irradiation of the neck? Has there been any contact with pets? In the physical exam, note whether the mass is midline or lateral. Does it move with swallowing? A midline mass that moves with swallowing generally arises from the thyroid gland. Is it tender to touch? Is it warm? Is the mass soft, firm or hard? Is it mobile or is it fixed to the underlying structures? Does it appear fluid-filled? If fluid-filled, does it transilluminate? This indicates a cyst. Can the skin over the mass be pinched or is it firmly adherent to it? Is the mass pulsatile? Pulsatile mass usually arises from a blood vessel. If an enlarged neck node is encountered, it warrants a full examination of the head, especially mucosal surfaces, from which the lymphatic drainage reaches the neck. Hence, the face, oral cavity, tongue, teeth, lips, saliva glands, oropharynx, nasopharynx, larynx, and hypopharynx should be examined. If direct examination of these regions is not possible, then it should be done by indirect mirrors or fiber optic devices. When possible, these regions should be palpated in addition to visual inspection. Other lymph node groups should also be palpated, such as the axillary and inguinal lymph nodes, as well as checking for spleen or liver enlargement. This is because lymphoma can present with multiple enlarged lymph nodes in the neck, as well as other lymph node groups, along with hepatosplenomegaly. Investigations. A quick and easy way to begin investigating a neck mass is with an ultrasound. Ultrasound can roughly define the consistency of the neck mass and which structure it arises from. For example, is it a thyroid swelling or a lymph node enlargement? CT scan can be used for more detailed imaging than ultrasound because it creates 3D pictures by putting together multiple images from different angles, and can also tell us the condition of the structures surrounding the mass, such as the mass encroaching surrounding muscles, blood vessels, etc. The CT scan can be used to image the head region, which could reveal a previously undetected primary lesion that may be causing lymph node enlargement in the neck. CT angiogram may be used to highlight any pathology of the blood vessels. Other imaging options include MRI and PET scans. PET scans are especially useful when trying to find the primary cancer site in the case of malignant neck nodes. Besides imaging, tissue diagnosis can be obtained by fine needle aspiration cytology, FNAC, of the mass. It is not recommended to go directly for an open biopsy of a neck mass, especially if there is a suspicion of a malignancy. FNAC can generally differentiate between a neoplastic and an inflammatory neck mass, but does not give sufficient histological detail. Sometimes the FNAC could be non-diagnostic and may have to be repeated. However, it should still be the initial step for tissue diagnosis. If the FNAC detects a neoplastic lesion, the next step might include a bigger biopsy sample, such as a core biopsy or even open excisional biopsy. This would provide a bigger sample for more detailed histopathological analysis, including immunohistochemistry. Blood tests include complete blood count. Raised white blood cell count could indicate an infection. Pancytopenia could indicate lymphoma. If the neck mass arises from the thyroid, then thyroid function tests are necessary to check for any underlying hypo or hyperthyroidism. Differential diagnosis. Based on the patient's history, physical examination, and investigations, the physician could reach the appropriate diagnosis. The differential diagnosis can be classified based on whether the mass is midline, for example, thyroid mass, or lateral, for example, lymphadenopathy. Whether it is superficial or deep. Does it appear to be a congenital lesion, such as thyroglossal duct cyst? Is it neoplastic, such as lymph node malignancy, lymphoma, or salivary gland tumor? Is it an infection, such as Ludwig's angina? Or is it a systemic disease, such as tuberculosis? Other diseases include laryngecele, head and neck metastases, hemangioma, and cat scratch disease. Management. The specific management of the neck mass would depend on the underlying disease. If a neck mass appears to be lymphadenitis and is present for less than 3 weeks, it is recommended to start the patient on a course of antibiotics. If there is no response to antibiotics, or the neck mass persists for more than 3 weeks, then a detailed workup should be done. Lymphoma would require chemotherapy after its proper grading. Tuberculosis would require anti-tuberculosis therapy, which is a prolonged course of certain antibiotics. Non-functioning thyroid masses may require thyroidectomy. Cancer cases should be discussed in multidisciplinary team meetings, MDTM, to decide the appropriate management option for that patient. Treatment options could include surgery, chemotherapy, radiotherapy, or a combination of all three. In the case of secondary metastatic neck nodes, some further workup is required, including random biopsies from certain areas of the upper aerodigestive tract in search of the primary cancer site. Does every sore throat need antibiotics? On your first day in the clinic, a patient comes and complains of his sore throat. Unfortunately, the clinic is located in a remote area, so you do not have sufficient tools to diagnose him. You recall in your med school days that sore throat has two main types. The first is viral pharyngitis, which needs to be treated symptomatically. The second is bacterial pharyngitis, which needs antibiotic treatment before it worsens and leads to other complications. Unfortunately, excessive or misplaced use of antibiotics can turn a common bacteria into an antibiotic-resistant superbug, which is a threat looming worldwide. On the other side, some patients insist they should receive antibiotics even after a single sneeze. How to deal with this? Many clinical features are differentiating bacterial and viral infection. However, a not perfect but simpler clinical scoring system to help in this decision-making is the Centaur criteria. It consists of 4 conditions. If 3 or more of these conditions are present, then it is highly possible that bacteria causes the sore throat, and antibiotic treatment is needed. If less than 3, then it may be treated symptomatically as a viral infection. The 4 points are as follows. 1. Tonsillar exudate, or white spots on the tonsil area. 2. History of fever nearby the time of onset. 3. Absence of cough, as the cough is more likely to be caused by a viral infection. 4. Small and painful swelling or tenderness on the anterolateral side of the neck, near the lymph node.
Thank you for your continuous support, especially our valued patrons and members who have been encouraging us to keep producing more quality content.